Good afternoon, everyone, and welcome to Grand Rounds. My name is Tom Farden, and I'm the chair and organizer of Grand Rounds. And on this sunny day, out of my window back there, we kick off into a run of infection-enriched Grand Rounds, which is very nice. It is, I think, Antimicrobial Awareness Week next week, or the week after, or something like that. And we have a run of Grand Rounds that are going to be focused around infection. And we kick off with this, and I've erroneously been calling this Clostridium Difficile Infection, and it has a new name now, which is Clostridiroides. But Victoria and Alan are going to tell us all about CDI, C. diff infection, the microbiology, the diagnosis, and the treatment thereof. So thanks very much for joining us. If you have a question, please put it in the text chat. Otherwise, you can put your hand up at the end. And Victoria, I think, is first, and then Alan.
Thank you so much, Tom, and thank you everybody for coming today to listen to us talk about C. diff infection. So I'm Victoria Austin. I am a clinical scientist in microbiology, and I'm here with Alan.
I'm Alan Smith. I'm an infection prevention control nurse for NHS.
So I'm going to take the first part of this presentation, and I'm going to talk about C. diff microbiology and diagnosis, and then I'm going to hand over to Alan for what we do once we have a diagnosis. Hopefully my slides are going to move on. Yes, they are. Okay, great. So as Tom already alluded to, C. diff has had a bit of a rebrand. So it used to be called Clostridium Difficile, and now it is Clostridioides Difficile, but really those terms are interchangeable. And people will know what you mean if you say Clostridium Difficile. We're going to be talking today about two particular aspects of this bacteria, which are particularly important and explain both its pathology and its transmissibility. So the first is that C. diff has the ability to form spores. You can see in this electron micrograph here, we have the bacterium, and this red blob in the middle, that is a spore. And essentially what spores are, they are a copy of that bacteria, which persists in the environment. It's really, really hard to kill. And it's those spores which are infective to the next host. C. diff is also a toxin-producing bacteria, and I'm going to talk more about that later, but it's these two features together that determine both the transmissibility and the virulence of this bug. So the fact that it can form spores means that the spores are resistant to alcohol hand gel, whereas the bacterium itself would be killed. And they can persist in the environment, and Alan is going to talk more about that later. And it's the toxins that are produced by this bacteria which cause the symptoms of C. difficile infection. So just to set the scene, of where C. diff affects the human host is in the digestive tract. Now, a healthy digestive tract has a variety of bacteria all living in harmony, much like a healthy society is really diverse, so is your gut. The bacteria that live in a healthy gut are called your microbiota. And these gut bacteria, these different populations, lots of different species, they control each other, and they make sure that no one species is able to outcompete all the others. They do this through two main mechanisms. The first is resource limitation. So they basically eat all the food so that no one bacteria can proliferate too much, but they also sometimes produce byproducts, different compounds which can suppress each other's growth. Now, when you disrupt this healthy gut microbiota, this can lead to a single pathogen flourishing and then able to cause symptoms in that host. Now, disruption can come in many different forms. One of the most important ones from our perspective is the use of broad-spectrum antibiotics, but other things can be important too, such as proton pump inhibitors, which act to change the pH of the gut and move it from a more acidic environment to a more basic environment. And when the pH is increased and becomes more basic, some bacteria, for example, C. diff, can thrive more easily than in an acidic environment. There are other things that can change your microbiota too, such as a diet change or your environment. Now, this diagram here demonstrates what happens when you have disruption or dysbiosis. So on the left-hand side, we have a really diverse environment in that gut with lots of different bacterial species all there in harmony. And these dark blue blobs in the middle, these are the Clostridium difficile bacteria, and you can see it's just one of many. Now, after, for example, the use of broad-spectrum antibiotics, which wipes out a lot of this healthy bacteria, you can see that what you're left with is dysbiosis. You have an overabundance of C. difficile in this background. And when you have a C. diff population which is allowed to thrive and is not kept in check, that is when we are at risk of symptomatic C. difficile infection. It's important to recognise that it's not just the presence of C. diff in the gut that's important. It's when that environment changes and the C. diff is allowed to proliferate that symptoms arise. And the symptoms can be Described in many different ways. So people call it CDI, or Clostridium Difficile Infection. It may also be called antibiotic-associated diarrhea, or AAD, or antibiotic-associated colitis, AAC. Different terminology, same end result. What is important to recognize, though, is that a patient or a human can be asymptomatically colonized by C. diff. And if that C. diff is kept in check by these other bacteria in their healthy gut, colonization is common, it's often temporary, and it will be asymptomatic. So it's only when C. diff is allowed to thrive that it becomes a problem. And this is really just a diagram demonstrating what happens with colonization. So first of all, you have a healthy host who has no C. diff in their gut, and at some point they'll acquire C. diff spores from the environment. It happens really, really commonly. This colonization might be transient, so just a one-off positive. You might then end up with a persistent colonization in some people. For various reasons, you may become persistently colonized. However, this person will still be asymptomatic unless a risk factor is introduced, for example, broad-spectrum antibiotics, which will potentially develop C. difficile infection. And this is because CDI is caused by toxin production and not by direct action of the bacteria itself. So the bacteria is not an invasive pathogen, but the toxin acts on the cells to cause the symptoms. There are several different toxins carried by C. diff bugs. Not all strains are as potent as others. There are two particularly well-known ones, which are toxin A and toxin B. And of these two, toxin B is the most important. Without B, generally, you don't have disease. There's a third toxin, which is becoming more and more well-known and is considered to be more and more important, and that is binary toxin. There's not a huge amount of research into binary toxin. It's relatively newly characterized. But what is likely is that when you have binary toxin, it sort of amplifies the activity of toxin A and toxin B. And this can lead to so-called hypervirulent strains. Now, these hypervirulent strains have a number of virulent factors. For example, they are often more transmissible, so the production of spores from an infected host is increased, but also you may have worsening disease, you might have an increased risk of recurrence, and you might have a higher risk of treatment failure in the presence of binary toxin producing C. diff. And I'm going to be hammering this point home throughout this presentation, but without the toxin, there is no pathology. So a C. difficile bug may not be carrying the toxins and therefore will not be able to cause disease. This is really how C. diff bugs work and cause symptoms. So you have germination of the bacteria in the gut, and that's what we call it when the spores go from being a spore to being an active reproducing bacterium. They produce the toxins which act directly on the cells in the mucosa of the intestine. They do a couple of different things, but the main important things that they do is they cause disruption in those tight junctions between the cells. So you can see the disruption of the epithelial barrier. And this epithelial barrier is really important for a number of different reasons, but one of them in particular is fluid accumulation. So this fluid control from the mucosa, from inside the gut to outside the gut. And you can see that when you have a dysregulation of this fluid accumulation, that is what leads to watery diarrhea, because all the fluid is not being removed from the colon. You also end up with a disruption of the epithelial barrier through cytotoxic effects. So the cells actually die, they break down, and you can end up with bloody diarrhea as a result when the cells in the mucosa are breaking down. And then finally, you end up with a massive inflammatory response, and you get an accumulation of white cells and fibrin and all these sorts of like inflammatory associated products, causing what we refer to as a pseudomembrane, and you can see that here, which is these white plaques on the mucosa. And this is a double-edged sword, so you end up with a breakdown of the mucosa, and you also end up with this massive inflammatory response inside the intestines. So CDI is a range of presentations from mild to life-threatening. The onset of symptoms can be really variable, from as quickly as 1 day after antibiotic exposure to several weeks later. And a mild presentation may be limited to watery diarrhea, with sometimes bloody diarrhea, though this is less common, and just classic symptoms of abdominal pain, fatigue, and malaise. However, severe infections can be life-threatening, and they can include things like fulminant colitis, a very high fever, abdominal pain, and distension. And it's also important to recognize that in severe infections, the patient actually may no longer be producing diarrhea because of paralytic ileus in the gut. So no peristaltic action is occurring, and therefore there will be no diarrheal production. We would urge everybody to check the formulary if you suspect C. diff in a patient. There is a severity score against which to check for particular markers of severe infection, and if you go to the formulary, you'll be able to see this. So this brings me on to testing. Classically, the gold standard for diagnosing C. diff was culture. This is what C. diff looks like on a culture plate. These little fried eggs, each one of these is a colony of C. difficile bacteria. However, it's quite time consuming. It's not necessarily the most sensitive method. And so this is not how we routinely diagnose C. difficile anymore in Scotland. First thing I want to say about testing really though, is that we only test symptomatic people. So no diarrhea, you won't get a test. Screening asymptomatic people will detect colonization and not disease. So we would be getting a lot of false positives and potentially a lot of people would be getting antibiotics who did not need them. Even if you're symptomatic, however, it's not enough to just detect the bacteria. We need to know whether that bacteria is actually producing the toxin and causing the disease. And therefore, we do what's called a two-stage process to first detect the bacteria and then to see if it's toxin producing. So that screening test we do here is PCR, and it looks for two genes, either toxin B or binary toxin. Now, having this gene just means that the bacteria has the potential to produce the toxin. It's not necessarily doing so. And if you were to get a positive result for a patient, this is how it would look for a toxin B gene positive, and this is how it would look on ICE for a binary toxin PCR positive. So you would get a hypervirulent C. diff result. And they all come with this comment. And this comment basically says a toxin test is required. And that is because we are doing the screening test, but the toxin test is the confirmatory assay. The confirmatory assay we do in Tayside is called VIDAS toxin assay. And it's not really that important how it works, but basically it's a color change. The change of colour occurs in the presence of the toxin, and actually this diagram does not show the assay that we do, but I couldn't find a good picture of the assay that we do, and it's the same principle. Basically, it goes from clear to coloured. Now, if this second test detects if the actual toxin is produced, this second test detects if the actual toxin is produced, but it's less sensitive than that screening test. So if we just use toxin detection, we'd actually miss a lot of patients, and that's why we do these two tests together, a really sensitive first test and then a more specific second test. So if your screening test is positive and your confirmation test is positive, you'll see this on ICE, which is a C. difficile toxin detection result, and it will say here, toxin detected, and you get a little comment explaining it as well. And therefore, we would say that this patient would meet the definition of C. difficile infection if they have both symptoms and they have a positive by both of these tests. However, if that screening test is positive, but the confirmation is negative, so we're not able to detect the toxin, we report these as indeterminate. And there are two potential reasons why you would get an indeterminate result. So first of all, the bacteria is present, but it's not producing the toxin. We would refer to this as colonization, potentially. And it likely means that there is another explanation for the patient's symptoms. The other alternative explanation is it's actually a false negative. So because this screening test requires the toxin to be at a particular level in order for detection, if the toxin is below that level, we might not be able to pick it up. And we would say, in that instance, if you review that patient and you think, actually, C. diff is still in my differential, I still think this patient might have it, we would urge you to send a second sample. And it may be on a repeat sample, that toxin is at a detectable level. So again, definition of C. diff, you require both testing and symptoms in order to confirm that it is a true case. So what should you do once you suspect C. diff or a positive result? Alan is going to go into much more detail about this here, but we'd urge you to go to the formulary. There is an excellent flow chart with a step-by-step algorithm for what to do in the case of a suspected or confirmed C. difficile infection. And after you've done that clinical review, after you've followed that flow chart and determined if treatment is indicated, I'm just going to briefly touch on this because the current protocol is oral vancomycin. The reason why we urge it to be oral medication is because we want that drug to be concentrated into the GI tract. And there's also information here on how to identify life-threatening C. difficile infection. And in that instance, we would urge you to be contacting specialist advice. And again, referring to the severity score. Now, the formulary is updated to the most up-to-date evidence. So please don't use this presentation to guide management. Please go to the formulary and access the most up-to-date treatment algorithm. And I'm going to briefly touch on recurrence, which happens in around 20% of people after their first episode. And we would think of recurrence as when symptoms initially abate and then return. And this happens within the first 12 weeks of that first episode to be considered a relapse or recurrence. It might be two different mechanisms. You might have a patient who is newly infected from a new external source and it's an unrelated infection, but it may also be because spores in the gut have managed to regerminate and re-establish an infection. And the management of a recurrent infection is slightly different than in a first instance. And again, please use the severity score. So just some final notes from me before I hand over to Alan. We don't test for C. diff in kids, particularly under the age of 2, although in the UK, sometimes they say under the age of 3. And that's because C. difficile infection in kids is exceedingly rare. There are some different opinions of why that is, but essentially colonization rates are high, but disease states are very, very rare. We also would say test of cure is never advisable. The spores and the toxin can linger for a really long time after infection, and really symptoms are the only indication for C. diff testing. CDI should be suspected in any patient, especially in patients with other risk factors who have diarrhea. We should always be suspecting CDI. However, interpret the results in accordance with that patient's presentation. And then a final note, if you suspect ileus, so you suspect a severe infection which has resulted in the inability of the gut to function anymore, and that patient is no longer diarrheal, you can send a rectal swab for culture and we will still be able to test for C. diff in that instance. So thank you so much. I'm going to hand over to Alan now to talk about actually what happens on the other end. Oh, Jesus.
Sorry, I'll just get here. Hi, I'm Alan. As I say, I'm the infection prevention control nurse, and currently I'm in 9 Wells Hospital. I'm not going to dwell on these slides because we've kind of covered this in the previous slides with Victoria, but I did want to sort of go back to spores. So as we kind of alluded to, the bacteria isn't particularly viable. So once it's outside the human host, once it's out on a hard surface or wherever, it won't live for very long. However, it does produce hardy spores, and these are very able to survive lots of different things, including disinfectants, heat, air, and so can be quite tricky for us to manage. The spores themselves are picked up either via direct contact or indirect contact from an infected or a colonized person, and it's usually transmitted via the fecal-oral route. The ability of these spores to survive in the environment have led to many outbreaks. I'm sure you're all familiar with particular like the Bela Levin, where there was an outbreak of lots of patients, and they found that some of the measures they put in place weren't enough. So that's what kind of led to reviews and a lot of the guidance that the infection prevention control team use now. So major risk factors for CDI, again, some of these have been covered, but current or recent infection within the current or recent use of antimicrobial therapies within the last 3 months increases your risk. There are, I'll go over a few later on, increased age over the age of 65, a previous diagnosis of CDI, prolonged hospital stays, serious underlying diseases, surgical procedures, including bowel procedures, immunosuppression, and use of protein pump inhibitors, as we discussed. So really all of the patients, not all of the patients, but a lot of the patients within NHS Tayside sort of fit into this risk group, either one or all of these. So how do we prevent it? So there's sort of 10 key areas, and that's what I'm going to go through. So first of all, early diagnosis. So a lot, again, Victoria's touched on, but I just want to go on what we define as diarrhea. So RHI Scotland defines diarrhea as 3 or more episodes of loose stools. But NHS Tayside is a bit more specific. We talk about type 6 or 7, and you can see the lovely stool chart there. So a type 6, fluffy pieces with ragged edges and mushy stool, and a type 7, watery, no solid pieces, entirely liquid. We do find that, and Victoria will attest to this, that the lab gets sent all sorts of different types of stool, but they will only test type 6 and 7. And they kind of say it should quote the actual container. Lovely, sorry, hope everyone's finished their lunch. We also, infection control team will, as soon as we suspect anyone with diarrhea, but particularly a CDI, we will advise use of a stool chart and fluid charts. And that's just really the stool chart just to make sure that we have an accurate record of how many episodes, and we also look at if there's blood and mucus in it as well. And that can help sort of define treatment, but also it helps us stop precautions, which we'll go on to discuss later on. But basically, once the patient is 48 hours clear of loose stools, type 5 or better, then we can go back to standard infection control precautions. And the fluid chart is obviously these patients are extremely at high risk of dehydration, so it's really important that we monitor that as well. So we've already discussed what a CDI is, and I just want to refer back to the severity assessment. And as you can see, the document from the formula is to the side here with the guidance for proven or suspected CDI infection. In particular, I just want to highlight the severity CDI score. It's really important that we document that on ICORA, and that it is and the patient also receives a daily review. Now, infection control will come and read the documentation, and we will advise you if you've not done that. So we also look to see if it's a true case. So this is more for reporting purposes to Scottish Government and RHI. But basically, if a patient has diarrhea and a CDI result that may have had some other cause, was there overuse of laxatives, was there another infected diarrheal, such as norovirus, we would look at that. And if actually the cause of the diarrhea was not related to the CDI, then we wouldn't necessarily report that. So implementation of surveillance. So there's two types of surveillance we do. There's local, and then there's sort of national. So let's talk about local first. So we use a system called ICNet. Now that logs every infection that the lab kind of processes that is an alert organism, and CDI is one of those. So when we get that over, we have to decide, is it hospital-associated, healthcare-associated, unknown, or community-associated? But basically, I won't go into all of these. You will have access to this to watch back. But basically, a hospital-associated is a patient that's been in hospital for more than 48 hours. Then we will sort of log that. And if we have several patients that have come from an area, or maybe or are currently in an area, we will follow them up, and then we will decide whether or not is this an outbreak. Sometimes if there's a lot of, if we're not sure as well, we'll send off samples for typing and things, but we will begin to then implement investigation, which I'll talk about later on as well. So this is just a bit more information about how we decide what is what. As you can see, there's the three. They fall into the four different categories. So national surveillance, these are kind of simplified into healthcare associated, which kind of covers the unknown ones as well as the hospital associated and community. So the left-hand slide, is healthcare associated infection, and this compares last year's and this year's data. So currently, NHS Tayside is below sort of the national average. So we are sitting at 12.6 per 100,000 beds, whereas that was last year. And actually, we've had a decrease to 11.2, which is excellent. It's also good, and we're also trying to do a 10% reduction in both of these figures. So that's good for healthcare associated. Unfortunately, we've had a slight rise in community. You can see we've jumped from 4.8 to 5.3, but again, we're still below national. But as you can see, there is across Scotland, there is a slight increase from last year. So it's really important that obviously that we diagnose and we report these, and it can help with our long-term plan and implementation of measures to combat that. And so one of the biggest measures and preventing the spread of C. diff is education. So if you don't know, you don't know. So everybody, including staff and visitors who enters a confirmed or suspected CDI cases environment, should be informed. So they should have a basic understanding of what a CDI is and how it's transmitted. And we do a lot of education around this. We do ad hoc. We talk about it at our planned sessions. But particularly, we're just trying to make it clear that everybody should know about it, particularly those who are involved in cleaning, because they need to know about how the ability for the spores to live in the environment, which I'll talk about again in just a wee bit. So the first thing I will probably do is when we get a result over from the labs and it's C. diff positive with the toxin detected, we will isolate in a side room. And hopefully staff will have isolated on 3 episodes of type 6 or 7, but unfortunately that doesn't always happen. So if they're not already isolated, that will happen immediately, hopefully. Ideally in a designated, with their own designated toilet or commode, hopefully an ensuite room, but that again, not all NHS Tayside has that facility, unfortunately. And if we're cohorting multiple patients, again, we will, this would be very unusual. If we ran out of side rooms, for example, we would put them in a bay, have their own nurse, and they would have their own toilet facilities and things like that. And I did mention this before, but we would isolate patients until 40 hours clear of type 6 or 7. Oh, what have I done? Sorry, I apologise. I pressed the wrong button. There we go. So, hand hygiene. We all know about hand hygiene. We talk about it all the time. It was World Hand Hygiene Day just back in May. But I just want to go over this again because this is one of the probably the most singlest important things that we can do to prevent the spread. So, first of all, being bare below the elbows. So no watches, roll your sleeves up if you've got long sleeves, and no stolen jewellery, things like that. No artificial nails. We see it all. And then it's thinking about the 5 moments, which you can see up in the top right-hand corner. I won't go over them. These posters are in most clinical areas, but the most important one, I suppose, well, 2 most important ones for C. diff in particular is if your hands are visibly contaminated and leaving the patient's environment or the patient, you will definitely want to wash your hands. And we advocate soap and water because the spores are so hardy. Unfortunately, alcohol gel will not inactivate them, so you must wash them off with soap and water, and that's that. Because unfortunately they're just so hardy. So the next one is personal protective equipment. So we would always advise use of apron and gloves when you are in close contact with patients. These must be applied at point of care to prevent infection before you go to the patient, and must be removed once you've completed either the task that you're doing with that patient, particularly if they're contaminated as well, and definitely on leaving that patient's room. And PPE, I don't need to tell you this, should be disposed of in the correct waste stream as well. Management of equipment and environment. Well, again, I've talked about this pretty much throughout. The spores are very difficult to kill. So, and there is very good evidence that equipment and environment do play a role in transmission of C. diff. So, particularly when patients have profuse diarrhea, it can lead to heavy contamination on floors, toilets, commodes, and beds. So we advocate the use of Titan Chlor Plus, which is a chlorine-based detergent mix, and we would advise applying to a surface, for example, a bed, for 5 minutes and then washing off with water. And that would include any other equipment that you might use with the patients as well. So we're thinking ECG machines, your stethoscopes, these should all be cleaned afterwards. But it's really important as well, although we recommend Titan Chlor, you must obviously see what the piece of equipment that you've got, whether or not it can withstand that cleaning. Ideally, if it can't, then we shouldn't be using it in the environment. But most things within NHS side can tolerate chlorine cleaning. Lastly, just about the C. diff spores, they can live up to 7 months in the environment. There's some evidence to suggest even longer, so it's really important that we do clean once a patient's discharged. Other things that we will ask for is isolation clean, where a patient has been in that room, and that would be all of the curtains would be changed, the floors would be cleaned with chlorine, all the toilets and things again would be cleaned with chlorine, as would all of the equipment. Antimicrobial stewardship. Well, we've got a great antimicrobial team within NHS Tayside working really hard to reduce inappropriate antimicrobial prescribing, and it's one of the most, again, another really important factor in reducing the spread of C. diff. So one thing we will do as well, we will look back in the last 12 weeks to see what antibiotics this patient's prescribed, and we will look over them. We're particularly looking at the antibiotics known as the 4 Cs, if you like, cephalosporins, the broad spectrum penicillins, ciprofloxacin, clindamycin. If we feel that there are some issues with this, we'll consult microbiology and also discuss with the antimicrobial team. And we've got some colleagues within the community as well who are working with GPs and nursing homes as well to look at reducing the burden of antibiotics within them. Because as you saw, community rates are increasing. So hopefully if we can stop it there, then it won't come into the hospital. Treatment, I won't go on with this too much because Victoria's already discussed this, so we'll skip this one. So what do the IPCT team do in an outbreak? Well, first of all, we will go to the area. Well, no, not just for an outbreak. We will investigate every single CDI that comes across on our system, which is described as ICNet. And we will look at patient placement. We will look at where what the allocation is in terms of where did they catch it? Is it community? Is it healthcare hospital associated? We will again look at antibiotics and things, but there's some things we would do specifically in the event of an outbreak. So we will do potentially an observation of practice, which includes equipment checks. So we're looking to see if there's any visible fecal contamination. In particular, we'll look at things like commodes and toilets. We'll do hand hygiene audits to ensure that staff are washing their hands correctly. Every single patient will put under contact transmission-based precautions, and we'll isolate in a side room, as I described. We'll initiate a daily checklist, and that's just a reminder of all the things we've already advised, like your hand hygiene, use of PPE. We'll monitor the cases daily, and we'll look at antimicrobial prescribing, looking to see whether or not it matches the formulary. And we'll advise enhanced cleaning of high-touch surfaces with chlorine. We'll report to Scottish Government via RHI, and then at the end of the outbreak, we'll do a debrief, sorry, and we'll discuss any lessons learned with the MDT. We will also do that with HAI severe CDI cases as well. So every single one will be day text and reviewed, and we are now hopefully getting not just the nursing staff, but also medical staff involved with this too. So to look at all aspects of it, not just from a nursing point of view, was prescribing right? Did we clean the commodes? Did people wash their hands? And if there's any lessons to be learned, then to be shared there. Just to summarise all of what I've talked about, so you'll all be hopefully familiar with standard transmission-based precautions, what we do for every patient every time, and that includes some of the things I talked about, so isolation, hand hygiene, cleaning of equipment and environment. And then on top of that, when we have a case of diarrhea, whether or not they have C. diff, pardon me, we will put contact precautions in place. And again, that's hand hygiene, use of personal protection equipment. We like to have the door shut as a visual aid, but also potential as to stop the spread of infection, and then removal of PPE on leaving the room. It's just a visual reminder for staff and visitors. All of this that I've talked about today on my presentation section can be found in the National Manual for Infection Control, which the link is there. The A to Z has specific instructions around what to do in the event of a CDI, and it links to the guidance that my PowerPoint is based around as well. So I highly recommend you have a look at that. And that was me. So I suppose any questions for us? So stop sharing that. Hello, everyone.
Thanks very much to both of you. There are 37 people in the audience, so any questions from the floor, do stick your hand up, or you can type it into the chat. Anyone got any questions? Nick Ray of this parish.
Hi, Nick.
Hi, folks. I was just going to ask about the indeterminate CDIs, especially with the change towards PCR for the kind of initial screening test. Are we getting a lot more repeat indeterminates? Because I just wonder, when people present with diarrhea and we've got these kind of indeterminate, or repeat indeterminate CDI results, and there's a question about, is this significant? Is it colonization? Given the increased sensitivity of PCR versus GDH, the kind of old screening test, do we think we're treating more people that are indeterminate? What do we think?
I love that Alan's like wheeled away. So actually, with the introduction of PCR, we saw an increased confirmation rate So we moved from about 40% of specimens confirming to over 50% of specimens confirming on that second test. So we actually think that we're picking up more true positives with the change in testing algorithm. As for whether we're getting more repeats, more indeterminates that then become a repeat test, we actually don't know. It was an interesting question, and it's one that we do need to look at, because obviously if those repeat tests are consistently indeterminate, that patient might end up inappropriately prescribed antibiotics, but it's also just a waste of lab resources to continually repeating to test somebody who does not have CDI. It is a piece of work that we need to do. We just don't really have a good way of tracking how many of those samples come in. It's on our radar to do. If you know of anybody who wants a QI project, send them my way.
Yeah, I mean, I'll see if I can find someone who's bored and looking for something to do.
Team board, it'd be a great project.
Thanks.
Thanks, Nick.
Kevin McConville has his hand up.
Thanks, Tom, and thanks for the presentation. It's really helpful. Just kind of comment, I guess, from a general practice perspective. I always feel a bit guilty. And I noticed your comments about lab resources and you get all sorts of stool types. Sometimes we do want to send stool types to you for culture just to rule out maybe C. diff is not always top of the list. It may not be even on the list, but on ICE for general practice, it doesn't let us send it without requesting C. diff when there's many a time we don't really want it. And then it comes back with kind of comments about not tested or not appropriate, but I don't have another option.
No, you're absolutely right. And it's actually, hopefully this will put your mind at ease, as it's part of our battery of screening tests that we apply or don't apply. So actually those comments are not necessarily targeted to that individual request. The lab staff turn on or off the tests depending on the consistency of the sample. So we do appreciate that it might not be in your differential, and then we send you a passive aggressive comment saying not indicated, but really that's on us. So yeah, we understand that.
So it's not that we're kind of trying to generate tests for you and work for you within it. It's just how the labs comment on it. That's just helpful to know. Thanks.
That's great context. Thank you.
A question in the chat. Richard Hanson, who is a pediatric gastroenterologist. Could we do more on screening at-risk individuals and preventing progression to full infection, particularly around hospital stays and needed antibiotics?
Probably.
Yeah.
Yeah, do you want to take this one?
Well, I think as I highlighted, the risk factors are so kind of broad and they affect so many of our patients. It is difficult, but one thing we do in the infection control team is that if a patient, for example, has had a previous CDI infection, it will be flagged up and we will investigate and see if that patient's been readmitted with diarrhea and then action that. But that's really about the only one we can do. I suppose it kind of falls into antimicrobial stewardship and just preventing it from that aspect. But I don't know if there's anything else we can really do.
There's some interesting look at people's antibody responses to the toxins, and there are people who are more or less at risk of developing severe infection based off their antibody levels. I wonder if that in the future will become more of an important aspect of flagging people who are at high risk. I have seen a really interesting piece of work that I went to a conference earlier this year, and they were looking at PCR results and the level of DNA that was detected on a PCR result and flagging patients at that point who were at high risk of recurrence and treatment failure. That's not something that we're able to do with the assay that we have in-house, but it may be that, again, as diagnostics develop, there will be a threshold above which or below which somebody may be flagged as somebody who is higher risk of recurrence or higher risk of treatment failure. I think that's a future technology. It's not something that we have here, but there are definitely exciting developments in diagnostic and screening.
I did read very briefly in the literature about like potential vaccines down the line as well, yeah, but they're very much in the future.
Right. You mentioned something interesting, one of you, that children don't get C. diff. I mean, never say never, but they don't. I look after the cystic fibrosis cohort in adulthood, and they're another group who really ought to get C. diff. They've got bowel problems to start off with. Their bowel flora is completely abnormal from the get-go, and until the advent of modulator therapy, they would get weeks on end of meropenem, tobramycin, ceftazidime, huge broad spectrum antibiotics, huge amounts. And until last month, I'd never seen a CF patient with C. diff.
That's bonkers.
In what, 20 years of doing it. It is, and people would often ask me, why did they not get C. diff when they're getting all these broad spectrum antibiotics? And just last month we had our first positive C. diff test, but she doesn't have diarrhea. So in fact, she has the opposite. So it's very interesting, and I don't have the answer, but I just thought I'd bring it up.
So one thing we do in hospitals, but that doesn't, it's not going to stop the infection, is that we will, it used to be called reverse barrier nurse, so we'll put the patients under contact precautions as a precaution. CF patients, so for example, in ward 3, where the CF patients normally would go, you'll know that they'll have the sign up. So they'll always have a side room, so that will decrease the potential exposure to asymptomatic cases. But whether, I don't know if that would be the only reason. It's quite unusual. Yeah.
That's really interesting. Thank you, Tom.
And in that time, I've had a question from DJ Cathcart. Has there been any correlation between the introduction of GI PCR testing and a decrease in the number of hospital-acquired infections, C. diff, over the same time period?
I think the simple answer to that, David, no. We haven't seen a consistent decline, have we, in the last 2 years?
No, if anything, I would have to look back at our figures, but it's pretty consistent. I don't have that data to hand, unfortunately. Sorry.
Sadly, no, we can't take credit for a massive decline in C. diff, having introduced the PCR. It'd be lovely if we could.
Okay, so I think we've run out of questions. There's no hands in the air that I can see. So that just remains for me to thank you both, Victoria and Ellen, for volunteering to fill a slot at Grand Rounds, and second for turning up. Next week, Grand Rounds is the Scottish Ambulance Service and Palliative Care. We're going to talk about work they've been doing to improve palliative care through the ambulance service. The following week, we have a talk on Mpox. So we're back to infection control and ID with some public health input. It's then Black History Month at the end of the month on the 31st of October, and into November, rib fracture analgesia, and then penicillin allergy delabeling with an antibiotic, World Antibiotic Awareness Week. So we've got a full program going all the way through to November. In fact, we're full all the way to Christmas. So thank you everyone who has volunteered to fill a slot. If you'd like a slot into 2025, then please let me know, because I have an entirely empty program. So please do get in touch to fill your slots. Okay, thanks very much to both of you. Thanks for those who have been involved, and I will see you all soon.